telehealth reimbursement considerations for wheelchair evaluations. My name is Julie, and I'll be the moderator today for today's session. Please remember before we get started to mute yourself, and questions can be posted in the chat box, which we will be monitoring throughout the session. I will go ahead now and turn it over to Dan Fedor, who is our speaker for this session.
Thanks, Julie. Good morning, everyone. Thank you for getting up early and joining me for this session today. We appreciate it. Hope you had a good ISS so far, final day here. So this session is reimbursement considerations for the telehealth wheelchair evaluation. A hot topic. There's been several sessions on telehealth during ISS. I've attended a few of them, and all good information. This one, we're going to focus a little bit more on reimbursement considerations. And we know that performing the telehealth wheelchair evaluation was relatively new due to the public health emergency back in March of 2020. And with that, there are some reimbursement considerations that must be given, as with any evaluation, because as we all know, the majority of the items that we're discussing, complex rehab mobility, is reimbursed by a third party. So even if we know the patient qualifies, they require the item, it's medically necessary. If it's not documented properly, then the payer, whoever that would be, Medicare, Medicaid, or any other insurance, won't pay the claim. So it's important to have that proper documentation in order to have qualified patients receive the items they're entitled to and medically necessary. Before I get started, dig deeper into this, again, I'm Dan Fedor, as Julie mentioned. I'm the Director of Reimbursement with US Rehab. We are a division of the VGM group located in Waterloo, Iowa. I'm not in Waterloo, I work remotely, but that is where the corporate office is. We're a member service organization, and I focus mainly on mobility reimbursement and funding, regulatory, all that type of good fun stuff that comes with dealing with third-party payers. My background is I worked for Medicare for 6 years, and then I was Pride and Quantum's Director of Education and Compliance for 13 years before taking this role with US Rehab about 7 years ago. So we're going to get right into this. And if you have any questions, please use the question chat box, I believe it is, and we'll pause and answer them as we go through the presentation. So our learning objectives, we're going to learn how to identify key clinical indications that are required for wheelchair bases and accessories. Of course, we have to identify that and then apply it to the telehealth evaluation. Describe how to accomplish payers' requirements using telehealth. And then know how to construct a successful wheelchair evaluation, again, for the purposes of a third-party payer, understanding what you see in the patient and what you're requiring or requesting for that patient. Before we get into what's required, I just want to go back a little into the history of telehealth, talk about the past, where it was before, the present, where we are today, and then of course what we expect coming in the future. So the past, and this is pre-public health emergency, and I'll just be using the acronym PHE as we go through, shorten that up a little bit. Telehealth is used, as you know, for medical information exchange from one site to another, electronic communication, usually something like this, seeing the patient, identifying their needs virtually rather than in person. And the past of this was there was something called an originating site. This is the location where the beneficiary had to be, the patient had to be to receive telehealth. There was also what was called a distant site, which was the location of the person doing the evaluation, doing the examination, the physician or the practitioner. And that was called the distant physician. And the telecommunication equipment is exactly what we know of today and talking about. Continuing on with the past, pre-public health emergency again, the beneficiary patient had to be in a rural area. So it wasn't applicable anywhere in the country as it is today. And we'll talk about what changed with the public health emergency. But the beneficiary had to be in a rural area, so it was exclusive to that. The second point was the beneficiary had to be in an originating site. They had to be located in a specific site. They list not an all-inclusive list, but an idea of what they were looking at. A valid originating site was never the beneficiary's home until there was a public health emergency in March of 2020. So the beneficiary, the patient, could not be in their home receiving telehealth. They had to still go somewhere. They just didn't have to have an in-person encounter if they were in a rural setting. So then we move into the present, where we are today. And today began in March of 2020. That's when the public health emergency was expanded, or the public health emergency expanded the use of telehealth, I should say, from what it was. Currently, this may be performed while the beneficiary is in their residence, as I mentioned on the last slide. And we all know this is a good thing for many reasons, not having to travel to an originating site, seeing their residents, which is where they're going to be using this product mostly, or a majority of the time. So understanding that how their residence plays into the part of especially a wheelchair evaluation. They do not have to be in a rural area anymore. It's national, regardless of where the beneficiary resides. That's the current telehealth policy waiver because of the public health emergency, which is still in place. It can be used for new, not just established patients. It used to be an established patient. Now it can be a new patient. Reimbursing telehealth visits for 80 new services was applied when this came live in March of 2020. Expanding provider types. As you all know, some of you may be therapists on the webinar this morning. You're now eligible to include physical, occupational, and speech therapy via telehealth. This wasn't permitted before. Reimbursing telehealth services at the same in-person rate. So then we look to the future. What's expected for telehealth post-public health emergency? Where do we go from here? There's a lot of unanswered questions, as you can expect. This was something that was expanded. It's called waivers are in place right now. And these waivers are in place to allow some of the things that we just mentioned and more. And we'll talk about some of those in a few slides. But the public health emergency began, as I mentioned before, in March of 2020. It has been extended in 90-day increments. And that's what happens. It is renewed every 90 days, as long as they see that it should be renewed. The current extension is scheduled to end in April of 2022. It was just extended in January. It was slated to end in mid-January, but several days before, it was extended again, another 90 days. So all those waivers, all the accessibility, all the remote, all the replacing in-person with virtual is still in place through April of 2022, at least nationally through CMS. Now, I know states have different requirements. So we have to verify that per state that you're working in, and if there's any restrictions, or with any other payers. This is with CMS, with Medicare, and those that follow Medicare. So what does all this mean? It means CMS realizes, and they did during this public health emergency, that remote services, this option, has value. Less personal contact while still being able to receive the equipment they need. They realize this. This is something that, I guess if you want to say one of the good things that came out of the public health emergency was understanding that remote is possible on a more broad scale than it ever was before, and the values there for the patient and for the treating practitioners or the clinicians that are seeing the patient. And while it's not a brushstroke that it can be used for everyone, I know there's conflicting opinions on that, on whether this can be used for every single person. It's really not. It's a case by case. There are some situations where telehealth visit, a remote virtual visit, really wouldn't be applicable for the patient. And there are some that it would be. And we're going to talk about some of those in the next several slides. So will the public health emergency changes, exemptions, expansions be permanent? Or will some of them be permanent? What do we think, or what do we know today? And what do we think is going to happen? So the future post-PHE, once the public health emergency ends, what do we expect? Or what do we know? The beneficiary's residence can be the originating site. I mentioned that earlier. Again, pre-public health emergency, it couldn't be. It had to go to an originating site, which still required travel, which still required the inconvenience of that. This is a big thing. This is important for many reasons. And we're going to touch on some of those pros, those benefits of this, as we already have. Expanded nationally, not just for rural beneficiaries. Another great thing, another great option for beneficiaries, for patients throughout the country, not just in rural areas. Treating practitioners, ordering practitioners to perform the telehealth examination, to perform examinations otherwise known as face-to-face in many instances, will continue. That is great. That's another very great benefit of this public health emergency that, again, we believe will continue on after the emergency has ended. The question mark is the licensed certified medical professional, the LCMP, the wheelchair evaluation, of course, performed normally by a PTOT, physiatrist. The ability to perform the wheelchair evaluation is possible. It's not confirmed. It's not a no. There's a lot of industry advocates right now that are pursuing permanent option for telehealth for this CRT mobility. And there's, of course, the industry advocates. I'm on one of the work groups, support regulatory and legislative efforts to extend and make this permanent under the waivers for the following CPT codes, which, of course, allowing PTs, OTs to continue to provide CRT through these codes virtually through telehealth. Again, that's not a yes yet. It's not a no. It's being advocated for strongly by many groups. And, we definitely believe there's value in this, that this should continue on once this ends.
Dan,
Then there's others, there's a lot of other. Yes, go ahead.
We just have a question in the chat about the term confirmed. What does confirmed mean? Has legislation been approved to keep this permanent for therapists? Can you reference legislation for us to advocate?
Okay, so for therapists, no, it has not been. It's possible. It is something that's being advocated for right now with the regulatory and legislative efforts, but it is not confirmed. We don't know yet. We're hoping so. We believe it will, but no, that is not. The other bullets where I do list the word confirmed is what we believe this will be confirmed. This will occur once the public health emergency ends under the LCMP, under the therapists. I put possible because it's possible. We don't know yet. So that's where we are with that part. The last bullet, and this was, we think about remote and waivers and virtual and telehealth, using all that language. This didn't apply just to the physician or the practitioner doing a face-to-face or the therapist. Those are two great pieces of this. But it also applies, and still does today, to all in-person. All in-person can be remote or virtual because of these waivers that are still in place. The ATP assessment, as you all know, for complex rehab, your complex rehab power wheelchairs and your complex rehab manual, at least again with Medicare and those that follow, an ATP assessment is required. This currently, if possible, and again, it's not a brush stroke that it's applicable to everybody, but when it does work and it is appropriate, can be virtual. Less contact, that's still in place and it's still allowed under these waivers, just as the home assessment is. Currently, all wheelchairs and scooters actually require an in-person home assessment per policy, an on-site. They use the word on-site in-person home assessment. That's again virtual right now. It can be because of the waivers that are still in place through April. Once the public health emergency ends, I put the word unlikely next to that because the thinking, again, and we never know, you never know how it's going to turn out, but unlikely that that will remain virtual as an option once the public health emergency ends, that this will go back to what's in policy, which is an in-person requirement, an in-person encounter, or the last bullet on this slide. So we continue on, post public health future, what do we expect to happen? And the advocates are promoting what are the benefits. There's a ton of benefits if you think about it. There's greater access. There definitely is. You think about, I've worked with some of our suppliers, some of our members that are trying to obtain the necessary documentation to move forward in providing the product to the patient that needs it. And you all know, if you're in this arena, it's not a 1 or 2 day thing. There's a lot of steps along the way, especially for complex rehab. Scheduling a face-to-face with the ordering practitioner, having the wheelchair evaluation, what's known as the specialty evaluation, usually with the PT or OT, getting the orders. There's a whole process in place. And if any of those are stopped or slowed down, obviously the end result is delaying delivery, because all these things must be completed and properly completed before delivery can take place. We can't go back after the fact, after the delivery date. So I think about a situation, especially I'm in a snow area, and if there's a storm, and it could be any reason, it could just be health even. Patient can't get out because they're not feeling well today. If there wasn't access to telehealth, which there is now, it gives that access, even to get to a wheelchair evaluation. If there's, again, a snowstorm, we have to reschedule, we can't get there. Well, now if it's virtual, we possibly can do this. We can keep the ball rolling, get that documentation that's necessary, which in the end result is the patient's receiving their product that is medically necessary more timely than it being delayed due to not having to delay an in-person encounter that doesn't have to be delayed now for whatever reason it may be. And just in general, even if it's not a snowstorm or it's not the patient's illness, they're not feeling well, just the inconvenience of having to go, just having to travel. And again, I'm not saying this is a brush stroke that it should be used for everyone, because it can't be. There are some situations where they're going to have that in person for best practices and just for the best outcome of the patient. But in some situations, possibly a person that's been in the chair, they're getting a second chair. They've been in for years. This is not a new injury. Possibly that would work for continued need in the process. And we're going to talk about that. If telehealth is an option to establish that the patient still requires the product, so it can be repaired by the payer. So again, greater access, more convenient, obviously less cost for both parties involved. And then the main reason this occurred was less transmission of illness. That was it. Less contact, less transmission of illness. So these are some, not an all-inclusive list, but some of the benefits that are there, and some of the talking points, I guess, is the way you'd say it when this is being advocated for. But then, of course, there's a counter to that, and there are concerns. There are concerns even by the industry, but there are concerns by those making the decision if this is going to be approved or continued in the future, and the safeguards in place to make sure that the concerns don't occur. Accessibility. Some patients may or may not have accessibility to remote. That's not really a reason not to have it. Of course, majority do or could, and that's a good thing. But accessibility is a concern. Patient inability to use technology. Some of the patients may not be able to do that properly, but again, that can be overcome with education, training, in some cases. Again, not all, but in some. It could reduce patient care in some situations. Like I said, it's not all, it fits, all fits one. There may need to be in-person encounters in certain situations. and that's a case-by-case basis. But the point of what we're trying to make, well, with those that are making the decisions, whether this will be allowed and to what level it'll be allowed in the future, is that option should be there. And the practitioner, the clinician, could make the decision, the appropriate decision of whether or not this is an option for this specific situation or it's not, and take it from there. So the option is what's important. Assessing the patient per the current policy requirements. And that's one thing that we're going to continue to talk about after we finish the future of the post-public health emergency. We're going to dig deeper into the requirements. And this is important because the requirements haven't changed for mobility. The policy is the mobility assistive equipment policy. Within that, you have manual wheelchairs, you have PMDs with scooters and power chairs, and you have wheelchair options and accessories. You have wheelchair seating, which includes the cushions and the positioning accessories. The policy as far as what's required hasn't changed. So again, that's why I say it's not a one fits all, because the documentation still has to be there to justify those items, just like it was prior to the public health emergency. What I'm saying there is they didn't become more lenient, or there are not waivers to say you don't have to meet this requirement or this coverage requirement. What the waiver states is you can do a virtual if you can do a virtual. That's what it's stating. And then after public health, again, it will continue, but the policy, at least as of right now, hasn't changed. It's still the same policy and coverage requirement as it was prior. And we don't see that changing in the near future, at least. So what I mean by that is, even let's say the public health emergency ends in April of 2022. Again, that's when it's extended to right now. It's slated to end in April of 2022. If it does, we talked about what we believe will continue, what will continue, what's unlikely to continue. But even with that, the policy that's in place of dotting the I and crossing the T and ruling out least costly alternatives, providing objective measurements, that's all still required and will be. Then there's, of course, there's ethics and fraud and abuse. And that's definitely on the radar of CMS, of the fraud and abuse involved, just like with anything. And so that's something that they are concerned about. If it's expanded too much, is it going to be abused? Have to have safeguards in place and rules and regulations to hopefully not have that happen. And us as an industry, we want to police that. We don't want that to happen either, because as we've all seen in the past, if something is abused, not used properly, but abused, then it's either tightened up or it's taken away. And so I would be a strong proponent of everybody in this, is we kind of police ourselves if things are happening that are inappropriate, not compliant, trickle into fraud and abuse. We want to stop that. Otherwise, it'll ruin it for everybody, or could, which will take away the benefits, at least some of the benefits that we see here that are very important for the practitioners and the patient.
We have another question in the chat, Dan.
What? Okay.
Do you think we will see any pushback with a permanent solution to telehealth for OT-PT visits when our field is considered alongside routine outpatient PT-OT care?
Can you say that again? I'm sorry.
I think they're asking if we'll see, do you think we will see any pushback for a permanent solution to telehealth for therapist visits?
Oh yeah, I do. I do think there will be. And I think it'll come into the concern issue here, some of the things that I mentioned. So that's why several slides I had possible. We don't know yet. Right now, no. If it ended today, currently it's not going on after the waivers end for the wheelchair evaluation. The face-to-face, yes, with the ordering practitioner, but the therapists, no. So, but I say that because there's a strong, I think we have a good case. I guess that's the way to say it. There's a good, strong case as to why it should continue on But there are definitely challenges to that, and there are opposition to that that we're encountering. Otherwise, it would have happened. It would be there. But I do think, if I just had to say my guess in this, I do think it will happen. I don't know if it will happen immediately, but I do think it's going to happen at some point. One of the other things, I just want to talk about this for a minute before we dig into the actual policy part. And I think we're still good on time. Yeah. They always say, and this is not new, FMA, I don't know if you've heard of the FMA, Functional Mobility Assessment Outcomes, but the word outcomes gets a lot of play, and it should. It's critical. A lot of the market, when I say that, I mean the industry providing medical equipment and those that pay for it, are looking at this a lot more over the past several years. And this has been out a long time. Outcomes, we've talked about it. But within mobility, and in other areas, there's other policies and other areas that have it. It's really one of the most important things to be able to document. And I say this with coming from a background of Medicare. Again, I only worked there, it was almost 6 years. And that was right out of college. So I was in the 90s working at the Medicare contractor in Region A for the Northeast part of the country. But I dealt a lot with, back then it was called HCFA, back now CMS, of course, but I dealt a lot with them, and it's just a lot of government interaction in the role that I had. And, one of the things that always came up, and you all know this isn't nothing that I'm sharing, but they always say, prove it, show me that's, if we're going to spend here, we need to see the results. And it's usually driven first by money, of course, dollars. That's how much are we going to save? But more and more, and I mean, that's unfortunate to a point, but more and more, actually, the dollars are better, spent with the home medical equipment for long-term results and savings as well. So it's a win-win, really. And that's what I think we are doing with outcomes, is showing them that proof. Having one outcome model which gathers the information. I know right now, I think we have over 10,000 pieces of data, which we need a lot more. We need a lot more input on this. But for the future of where we are, and I add this into this presentation because telehealth is one of them. That's one of the other areas they're going to say, well, are we getting the same outcome if we allow telehealth as if there was an in-person encounter? And yes, in some, like I said, some cases, yes, that may be appropriate and some it may not. But when it is, we want to show it, because then it shows, yes, we can do this. This is a viable option, and the outcome is at least the same, if not better, in some cases. So I bring this into it again. This is the Functional Mobility Assessment Outcomes. If you're not familiar with it, I would become familiar with it. It is very, very important. Again, it's nothing new. This has been around for many years, but it's gaining more traction, traction, I guess is the right word. I was at some congressional meetings, virtual, of course, back in the spring, with, or actually the fall of last year. I'm losing track because of COVID. The fall of last year of 2021. Some virtual congressional, it was a fly-in, but it was a virtual fly-in because of COVID. And I was at some meetings, and all of them that we were at, that I was at with other members of the industry, they asked the question, and they asked us this. When I say they, I'm meaning Congress. And some of them we actually had, usually have aides or you have the staff, but we had some of the senators and representatives in these virtual meetings with us. And several of the things they asked were, would you have numbers on this? We were talking about mobility equipment. We were talking about the standing feature, the power seat elevator, just medical equipment in general, wheelchairs in general. And the questions came back to us about, what do you have on this? What kind of numbers? What kind of data? And of course, one is savings. That's the first thing that came up. The second was patient care. And together we said, well, we do have it. I think I'm going to lose my earpiece in a minute. Hang on. We do have it, and so we provided some of this to them. And so this is going to continue. This is going to continue. We want to use it as much as we can, especially within the telehealth area, to show the value. So let's talk about considerations here for reimbursement now. Identify some key requirements that must be clearly documented in the wheelchair evaluation. When you're considering health insurance, recognize how health insurers think and how to speak and write their language so they understand what you see in your patient. This is important even just for a regular wheelchair evaluation. Whether it's telehealth or it's not telehealth, this is important. You know, my wife is an occupational therapist, and she used to do wheelchair evaluations. She used to work in a clinic and do some wheelchair evaluations. And you know, me not having a clinical background, I have an economics degree, and just working at Medicare and being in the industry, communicating with her about what had to be in an evaluation, and some of the pushback I would get, and I would get pushback, was, why do I have to say that? And don't they understand that? You know, this is obvious, isn't it? And it's not. It is, maybe you would think so, but it's not to a payer in many cases. So an extra sentence or two, or thinking, will they understand what I'm seeing here in this patient, is really important. So you want to connect the dots in the wheelchair evaluation to ensure the patients receive the medically necessary product in a timely manner. That's important. Before I go on, are there any questions out there?
No, no new questions.
Nothing in the chat.
Okay, so one of the most important things, and I was in a session yesterday that talked about this, which was a great session by Catherine Sweeney from Permobile, about least costly alternatives and payers, you know, looking at that, and they do, you know, they just do. It's the language, it's out there, not always the best, but this is in there, and I can tell you that from working within, you know, for, like I said, almost 6 years and dealing with this. Even though they may say no or may have different opinions, this is out there, and that's where the FMA comes in to show that that may not always be the case, may not always be the best choice. But the point of this slide is just their language still is authorize the least costly medical appropriate alternative for the item that's being ordered. So unless the proof is in the documentation as to why something that costs less won't work, then they're not going to allow what you're asking for. That's the easiest way to say it. They want to, if there's something within the mix of products that we're looking at that's available and it costs less and it's not ruled out, as I have the words here, tried and failed or considered and ruled out, with a reason, a valid reason why, and that it's, again, tried and failed and why, or considered and ruled out, then they won't normally allow that level, that next level up. So if we keep that in mind for just a in-person eval, or especially a telehealth eval, both, it's really important to have this documented. And you know what they're looking at is identifying first a mobility limitation that affects their mobility-related activities of daily living. And again, I'm citing Medicare policy here because there's so many other policies. There's not really a session that we can fit into an hour or even a day talking about all the other insurers that are out there and their different policies. So this is Medicare as broad, you know, the big payer, and those that follow. And most follow to a point, if not 100%. But there are variations, so we have to check with each. You know, each insurance is different. But clearly, if there's an identified mobility limitation, and then the questions that they want answered are, can this be resolved? And I said earlier, I still have least costly alternative on the screen. Can it be resolved with a least costly alternative? And if it can't, why not? And I have cane, walker, manual chair, you see scooter there. And of course, accessories. This is one area where I see a lot of hesitation in payers, whether it be Medicare, some Medicaid, some MCOs, some Medicare replacement plans. United Healthcare is one of them that I see, where the documentation isn't to the point that they're willing to accept and approve. And so you have to keep in mind that when we're asking for additional accessories, and I say accessories, what I mean by that are, if we have a power wheelchair base and we're going to add a tilt and recline and have to operate the tilt and recline through the drive control, then we have upgraded electronics, and now we have a skin protection and or positioning cushion. We also have power center mount elevating legs. All that has to be justified, and there's many more with complex rehab, as you know, many more accessories. Each one must have documentation that comes from either the ordering practitioner or the wheelchair evaluation from the PT or OT, and it can't come from the supplier of the equipment. The ATP can't justify any of this because they have a financial relationship with the equipment supplier, so that's prohibited, at least with Medicare. Again, I know other payers may allow, but they don't. So the importance of this slide, what I wanted to bring up here is, as we move into, we currently can do telehealth. We've got to watch and make sure we use it appropriately, as we all know. We don't want them pointing at it saying there's fraud and abuse. We don't want to do that. We want to use it when it's appropriate and do that. What needs to be addressed is the same as what would need to be addressed in an in-person. As I said, that hasn't changed. So ruling out the least costly alternatives, identifying why they don't work, or why they're not a safe or reasonable option. And the final bullet, providing objective measurements when it's applicable to support the eval. This one, I do want to spend a minute on because it is more challenging in a virtual environment. As therapists, for those of you that are therapists on this session, you normally perform a wheelchair evaluation and document a manual muscle test, range of motion, pain scale possibly. There's a variety, and this is an et cetera. I didn't list everything, but there's a lot that goes into it, and that has not been waived because of telehealth. So that is a challenge, and that is something that's still, we can't say, I did it virtually, so I don't have X objective measurement to prove why they can't use the least costly alternative. That doesn't work. The least costly alternatives are important, as I said, very important. With complex rehab, once we move up to the patient requiring a tilt and recline, possibly an alternative drive device, it's not as important, but it's still important. And I say that because the patient has a condition, they can't perform a functional weight shift, they have a higher level condition, diagnosis, condition, and also medically necessary items that are being justified. It's easier to rule out the least costly alternatives in many cases. But even once you move into that, once you move up to complex rehab, there are still levels within that. And an example, if you want to provide a tilt and recline for a patient, that's what we feel they need because they are unable to perform a functional weight shift. The payer, whoever that would be, and I can't say 100%, but the majority will be looking at this because tilt alone is a least costly alternative to tilt and recline. Now, I know clinicians, and I talk with my wife about this as well as an OT, has a pretty good comeback to me on that. But I'm just relaying what a payer would think is you need to tell me why tilt alone won't work if you want tilt and recline for this patient. And there's a variety of reasons. There's valid variety of reasons, but it's not a given that the patient cannot perform a functional weight shift and it automatically pushes them into a tilt and recline. Payers are looking at that, whether it be, again, a virtual, telehealth, or it be a live, they're looking for that documentation to justify paying for a higher level item, which it is, it's a higher costing item, tilt and recline. And I'm just giving that as an example. There's a lot. And of course, within our time constraints here, we don't have the time to go through each and every one. But again, just to recap, the point of this slide is to make sure that whether it be virtual or telehealth, or whether it be telehealth, virtual, or an in-person, that these items are still addressed within the mobility eval. I didn't list everything because there's a lot. Again, you all do a great, as a therapist, a terrific job with what you do and your knowledge and your, assessing the patient. But these are key points that stick out to a payer, to an insurance. Again, whichever one it may be. These are the key things they need to find in order to move it to the next level. Some may pick more on certain areas, but this is generally what's happening within their motive and their mindset as they're processing and reviewing claims, whether it be a prior authorization or a post-pay review or a pre-pay review, whatever that would be.
Dan, there is one comment in the chat. Someone noted that they have had great success teaching the ATP who is in the home how to properly do manual muscle test and range of motion. Says, I don't always write down what they say, but take their subjective report with my observation to write appropriate manual muscle testing. And the ATPs have appreciated the education.
Okay, Julie, are there any other questions?
Not at this time.
Okay, well, I left a little extra time for that if there were any other questions. I know we're a little early here, but I didn't want to put too much in and run late. I know time constraints with this type of virtual session. But anyway, here's my contact information. Again, Dan Fedor it's dan.fedor@vgm.com. If you have follow-up questions, please don't hesitate to follow up with me. That is my cell phone. It's available. You could text, email, or call. And any follow-up questions or any comments even, I'd appreciate it.
There is another question that was just posted. It says, any idea when Congress will vote on making telehealth permanent for therapists?
Any idea on when this will be voted on or be considered? No, unfortunately, I don't. There's a lot of movement going on. There's a lot of, like I said, advocacy going on. But as of right now, I don't know when that's going to happen. Hopefully, it'll be soon, and we'll keep everyone posted, of course, through our communications if you're part of that or through whichever group you're in. I'm sure this is a big issue and it's being widely watched, and we'll keep everyone updated on that. But right now, no, we're not sure what's going to happen there or when that could possibly happen.
I have a question. Are there any required criteria to include in a telehealth documentation of, let's say, a wheelchair evaluation, which would be different from an in-person evaluation? I know at our institution, we have to document that it was telehealth and they are being seen via video, there are limitations, and the person is currently in the state, et cetera. They're consenting to a telehealth visit. So are there any standardized key points that have to go into our documentation that you know of?
Other than, like you said, acknowledging that it's a telehealth visit, and identifying what I would recommend. I say recommend because it's not a yes or no, but they do ask. When I say yes or no, it's not a firm yes or no. They have to have that, but why they did this, and even going forward, when I say this, why this was virtual, why this was telehealth, why wasn't it in person, especially now with the waivers, because now again it's under a public health emergency waiver. It's not after that. It's not. We're still within the waivers, what I'm trying to say. So yes, I would document why that occurred, especially if it's a switch from 100% in person prior to public health to 100% virtual now, which again, it's allowed. I'm not saying you can't go from 100% to 100% and everything could be virtual now because that waiver is in place. But I would have reasons, I would have it documented first that it is telehealth. As you said, everything you just mentioned is important to have in there, but as well as having a valid reason why this couldn't be an in-person encounter, I think is important. And I think that will be after, that one slide talked about fraud and abuse and the kind of concerns from CMS and from some other those that oppose telehealth being permanent. That's one of the things, I think, is what was the reason for this? This patient has a general practitioner. This patient has a therapist they see. Are you the therapist? And did we do this virtually because of a reason? Or do they have a physician they're seeing and now they're seeing another physician just for their wheelchair evaluation? Why was that? Couldn't they get in to see their physician? Were they concerned with, or do they have issues with traveling or accessing that point? Do they have issues with in person because of COVID currently? Those kind of things, yes, I think are important to have in there.
So current state, is saying that we're in a public health emergency enough, or you're saying we need to say more? I understand once that's ended, we definitely need to say, why are we doing it virtually? But current state do we need to include more than that?
I would, yeah,
Okay.
I would. Currently the waiver is just, it's a public health emergency, you can do it. But again, I'm thinking long-term beyond that, so the look back isn't, well, this was just available. So it was, again, this is not my words or not, I'm going to say it, so it is my words, but it's not my thought, was this abused? Was this abused? Should we not allow it? Should we restrict it in the future? Or are we going to allow it and then watch it? And if it's abused in the future, if it's again a brushstroke, do they question it? Payers are going to question a lot of things, as you know. This is new relatively, because again, it was limited to rural, it was limited to an originating site, so there were already hurdles in place. Now it's wide open. So I just think having a reason is important, and a valid reason, of course, is important for this.
There is another question.
Again, not required, I don't say that.
Right.
Oh, go ahead. Yeah.
There's another question that popped up. It says, in a few states, the PT/OT license does not specify if telehealth is covered under the scope of practice. It does not specifically say they cannot practice via telehealth. What is your view on PT/OT practice if this is the case?
Yeah, that's a good question, and that unfortunately I'm not going to have a good answer on that, because it is like what I mentioned was CMS's policy on national on what they will accept for a Medicare patient and those that follow. But as I mentioned, per state there's different requirements and approvals or disallowing in states, each one. So it would have to be a verification with them and with your agencies and organizations within that state if it's going to be accepted. I wish I could answer that broadly, but I don't know.
Any other questions, comments for Dan?
Well,
I
again,
do
you
just
have,
wanna-
you all have my information.
Yes. And I do just want to stress about what Dan said, about spelling it out in the insurance's language, payer's language. It's almost like that show, Are You Smarter Than a Fifth Grader, right? You have to spell it out.
Yeah, exactly.
Step by step. What we think as therapists is obvious, like ruling out cane crutch walker for a complete quadriplegic. You still have to rule it out, as an example. So I've even had examples when I'm trying to submit for specialty beds, the enclosure beds, and they want to document why less costly alternative, document that they've been tried and failed, so how do you do that without injury to the client? It's just interesting.
Right. And Jill, that's why, one of the things in their language is to tried and failed or considered and ruled out. So at least do that. I mean, yes, you don't want to try and fail to cause injury, but at least consider it and say, I've considered it. I considered this, ruled it out because, and then explain why, and then back it up with objective measurements. If it's applicable to objective measurements. That closes the
They
circle.
seem to forget to
that
read
really
that
does.
part.
Yeah, they do. So there's that too. But at least getting it in there, then you
Right.
can point to it if you have to. But that's the thing. If it's not in there, and in a denial and an appeal, you have nothing to point to because they're right technically. They're actually right if it's not proven. Yes, through a lot of appeals, you'll probably could still win and have it covered. But we want to avoid all that. Just like I mentioned, it might take an extra sentence or two up front, and it might. And obviously, nobody has more time to add an extra sentence or two or three up front. But it's better than having an addendum on a back end. And of course, that delays delivery to the patient. You got to go back and forth then, because everything has to be 100% perfect before delivery. Otherwise, it won't be paid for. So the front end of just taking that extra step, believe me, from seeing this and working it, and being inside with claims processing, I managed claims processing as well for Medicare back when I was there. Just from seeing that, knowing that that helps the process, so much, having that extra upfront, connecting the dots so they see what you see in writing. If you can think about it that way, it really does help.
There's a few more comments that are trickling in. One in regard to the scope of practice. It says, I would say if States Practice Act does not have language around telehealth, defer to AOTA or APTA for guidance.
Good.
And another comment, we have had to fight this with some Medicaid payers that didn't trial and fail, which is a safety and abuse measure to try and fail. Yes, similar to what we're talking about.
Yeah.
Finding this most often with safety beds. Agree. Our solution has been to get a demo hospital bed in the clinic to allow a trial and document failure, in quotes, in a safe way. Also, since COVID variants keep coming, do we have any indication when or what parameters will officials use to lift the PHE?
Yeah, no answer on that one. But you're right, they do keep coming, and they've been extended now since March of 2020, which was the first one where the was first announced and implemented. And every 90-day increments, it's been extended. If I had to guess, I would think it's going to go again another 90 days. We don't know, we never know, but I think it will go at least another 90 days beyond April. But then we don't know after that. All right, well, thanks for joining me, everyone. And thanks for joining us, and hope you had a good ISS. Again, contact info there. Any follow-up, don't hesitate. I'll answer anything that I can, and if I can, I'll try to find an answer for you. And enjoy the rest of the show and your week. Thank you.
Thank you, Dan. I am going to say the session code, and I also typed the session code. The code for this session is 9D6CGG. It is also on the chat.